What's up, guys? It is March 12th, 2026. It's about 5 a.m. Um, a few weeks ago, I finished my fifth block of words, and right now I'm in the middle of my night's rotation. Um, but I have tomorrow off, which is nice. So that's kind of why I'm awake so late. It's been a while since I made one of these learning issue videos. Um, and so I did want to make another one. Just kind of reflect on the past few months and make sure I document some learning issues so I don't forget. Um, but overall, I think things are better than they were a few months ago. I mean, I'd be lying if I said I still don't second guess myself every day. I still more there's at least one or two moments every single day where I feel like an idiot, where I'm like, you should have known that. But overall, I feel like I'm getting better at things, with efficiency, um, with medical knowledge, um, and I'm not as stressed as I was last semester, if you will. But I'm still pretty stressed. It's March 12th. If everything goes well, God willing, I'm going to take step three like March 24. So, I really want to get that exam out of the way. So I'm pretty stressed about that. I'll make a video about that as I get closer to step three. So I'm stressed about that. And, I know that there are gaps in my medical knowledge, so I've been trying to work my way through the mix app, the internal medicine, question set. And I got through the pulmonology, I got through the general internal medicine, but I still don't feel great about like gastroenterology, and I feel better about cardiology, but I still have a lot to learn. I still have some gaps in my knowledge that I feel like need to be filled. But I don't know, cautiously optimistic about things. So let me focus on some learning issues from my last few blocks of words and my current night's block. Um, I think the biggest learning issue that I'll focus on first is that um, you always need to be proactive. I mean, this is a job where you can't be overly relaxed, at least not as a resident. You always need to take every concern seriously. And so, for example, on my last words block, I had a patient who was hypotensive. Their blood pressure was low. I got texted by a nurse, and I already knew this patient had was having poor intake. Pretty much all they drink was like soda, um, and so I saw the patient, and they seemed okay. I mean, mental status wise, they were fine. So um, I said, they're probably just low on fluids, so let's just give them some fluids. Um, so I ordered like a liter of fluids. Well, sorry, like 500 milliliters of fluids, and the patient was still hypotensive. The blood pressure was still low, and so my senior went to go see the patient and said, um, um, well, basically, you know, the the patient the patient remained hypotensive and um, albeit without fever, um, but we were concerned about sepsis, basically, and that's something which I should have caught, something I should have considered instead of just let's just give this patient some fluids. So the learning issue that comes from this is that when a patient has low blood pressure, you should always consider a few things under differential, okay? Because it doesn't, you can't just say, oh, they need fluids, right? There's like four different types of shock, right? Um, Septic shock, hypovolemic shock, cardiogenic shock, and like neurogenic shock, um, obstructive shock, pulmonary embolism. Anyways, when you see that patient, those things should be in your head every time you have a patient with low blood pressure, right? And so, something you should always do is, check their extremities. Are their extremities particularly warm or particularly cold? Because if it's warm extremities, that would kind of suggest more of like a sepsis or hypovolemic picture. Um, if they're cold extremities, then you'd be worried about like a cardiogenic shock. And then, of course, the clinical picture is always important. I mean, this patient had a wound on the right lower extremity on the right leg, which was looked like venous insufficiency. Right, she has chronic like redness, on both legs. But as it turns out, in the context of being septic and this wound, being more painful than before, this wasn't venous insufficiency. This was cellulitis. Okay. Um, and so the clinical picture matters too. And so, this was kind of an interesting case because she didn't have a fever. She didn't, her white blood cell count was chronically elevated from other issues, but, she was septic and I should have caught that, and of course there's criteria for sepsis whenever you're worried about it, like SIRS criteria, QSOFA criteria, and I don't know them off the top of my head, so let me just get into SIRS criteria here because it's important. Yeah, so fever is one of them. Heart rate over 90 is one of them. So I went through the chart and I did this that day, and it's like, oh, the heart rate actually did go up to like the 90s. Um, Respiratory rate over 20, and then elevated white blood cell count, which was chronic in her. And then, of course, there's also like suspected source of infection. Yes. So, these are things which need to be going through your mind every time a patient's hypotensive, right? You need to be very proactive. You need to be thinking about these things. Um, so, anyways, now if it's not one of these, four types of shock or four types of, or if it's not hypovolemia, um, and of course, you can assess for hypovolemia too. You can look inside of their mouth, see if they have like dry mucous membranes. Check their ins and outs. Unfortunately, oftentimes the ins and outs aren't charted unless the patient has heart failure or something, and there was orders to chart them. So, but these are things to consider. Um, but anyways, let's say it's not one of those etiologies, right? It's again, pulmonary embolism, right? Does the patient have shortness of breath? Is the patient on DVT prophylaxis? Um, you know, Anyways, if it's not one of those etiologies, if it's not one of those causes, then you should always also check their TSH and check their cortisol level, right? Because hypotension, low blood pressure resistant to treatment is concerning for adrenal insufficiency. And so I also had another patient who we give the patient fluids. The patient was already on antibiotics. Blood pressure just did not get better. Um, and so we checked the cortisol in the morning. Sure enough, the cortisol was low. And so we did a cosyntropin stimulation test, right? You check the cortisol, you give ACTH, you check the cortisol again, and then or cosyntropin is another name for ACTH, and then you see if they have that adrenal insufficiency or not. So that should always also be on your differential. One more thing before I get off this hypotension topic is something else you can do for patients is you can do what's called like a leg raise test, or what's easier to do is like a Trendelenburg test. And so, um, what you'll do is if the patient's lying flat, you'll lower the bed so the head of the bed is lower. That pulls blood, fluids to the head of the bed. Um, and to the arms where the blood pressure is measured. And so you'll Trendelenburg them, then you'll check the blood pressure again. If the blood pressure is significantly higher in that Trendelenburg position, then that means they're responsive to fluids. So which suggests that it's either like a hypovolemic or a septic cause of this issue. So anyways, long story short, you get a patient that's hypotensive, you always need to be considering all these things. Okay. So that's kind of like one of the learning issues which really stuck with me, because I was like, if my senior wasn't there, I wouldn't have caught that sepsis. So um, the next thing is just being thorough. It's something I still need to work on. I mean, I get to the hospital at like 4:50 a.m. On wards, on long call and short call days, and on post call days, I get there even earlier, like 4:30, and it's it's not good. I need to be more efficient. And um, because in a few months I'm going to be a senior. I'm going to have twice the amount of patients. Um, but anyways, the key to becoming more efficient, because I'm getting there, is is having both a workflow and I don't know, just making you need to make sure that you're thorough and efficient, right? Because when you're not efficient, I mean, when you're not thorough, and even if you're efficient, then you're gonna miss important stuff, and you're gonna be doing these presentations like I was earlier in the year, where the attending's gonna be like, well, what about the fact that the patient was febrile overnight? What about the telemetry showing this? Right. And I was like, oh, I didn't look at that. Right. So you need to have a method to look at everything, and you also need to have a method to be efficient. And so the key to that is just having the same method every time. And so um, I'll give kind of two workflows. One of them is the morning workflow. You get there in the morning to your ward shift. What do you need to look at for every single patient? So first thing you're gonna do is you're gonna, you know, and it's different based on the hospital. What I'll do first thing is I'll print the summary sheet for every patient. The summary sheet should already have, assuming they were drawn that morning, it should already have the labs and then the kind of the last set of vitals for the patient and the kind of the medications that they're on right now, and also their PRNs. Um, Now, regardless of whatever's on that sheet, what you should do is on the EMR, you should first look at the vital signs. Um, are they stable? Write down the last vital signs. Um, Look at the vital signs, not just the last ones, but like throughout the night. Did they have a fever overnight? Did they have a drop overnight? Um, and then, with the vital signs, if the patient is on telemetry, cardiac monitor, let's say the patient has atrial fibrillation, let's say we put the patient on cardiac monitor for another reason. I don't know, maybe the patient's post-stroke, maybe the patient has, heart failure. We're wondering, if the cause of that heart failure is because of, an ischemic etiology, if the heart failure is because of a heart attack, to put it simply. Anyways, let's say the patient's on cardiac monitor, you want to look at the cardiac monitor. Now, and my hospital, it's a pain. It's annoying, okay, because I got to log on to a different system to look at the cardiac monitor. It takes a long time. It's annoying, but you got to look at that and at least note if there's been any alerts overnight. Oftentimes there are alerts. Oftentimes it'll say ventricular tachycardia for how many number of seconds, and unfortunately you have to go look at the telemetry strip during that alert, and then oftentimes it's probably just like a PVC or something, which that's a learning curve in and of itself. Kind of recognizing, is it actual ventricular tachycardia? Was it a PVC? Was it atrial fibrillation, or was it a multifocal atrial tachycardia? It's a learning curve, and I'm trying to get better at it. But anyways, vital signs, telemetry. Look at the labs, not just what you printed in the morning, but the phlebotomists are actively drawing stuff, at like 5 a.m., 6 a.m. So make sure you look at the labs on the EMR. Then look at diagnostics. Have there been any new X-rays, um, any new imaging, any new EKGs, anything like that? Look at diagnostics. If the patient has an infection, look at the microbiology tab. Um, I'm talking about Cerner here. I don't know how it is on Epic, but there's a microbiology tab. It's going to show you, have the cultures grown anything? Have the cultures even been drawn yet? You want to look at that. So, right, vital signs, telemetry if needed, um, labs, diagnostics, microbiology. If the patient has diabetes, you want to look at there's something on Cerner called a core diabetes flow sheet. Again, this is something that comes with time because it's annoying. You have to go to you have to click on some weird stuff, whatever. But you need to find your way to the core diabetes flow sheet. If they have diabetes and you want to see, well, how much insulin did they get overnight? How have their blood sugars been? When did the blood sugar peak, if it did peak, things like that. Um, so then you look at all of this, okay? Then you want to look at the notes, and then you don't just want to look at the physician notes, like, if you're obviously, if you're consulted general surgery, if you consulted cardiology, if you consulted whoever, you want to read their notes, right? But also you want to make sure you set your notes to like see all the notes, so you can see the you can see the physical therapy notes and other notes, because the physical therapy notes are important for discharge. Um, those are the notes which are going to tell you whether or not they recommend the patient goes home or whether or not they recommend the patient gets rehab. It's important to look at those every day. So you look at all of that, and then what you want to do is uh, look, and then you look at the notes. Then you want to look at your plan. You want to look at the problem list. Are there any new problems today, right? If there are, you want to add those to your problem list, and then you want to basically, what I do is I write my note in the morning, most of my note in the morning, with kind of like some bullet points on things that I'm thinking about doing. Um, so all of that, should take about, for me, it takes about 20 to 30 minutes per patient. I'm trying to get better at it. I'm trying to get faster at it, because right now I'm carrying maybe 5 to 6 patients, on wards, maybe sometimes up to 7, maybe. When I'm a senior, I'm going to be carrying, like 14 to 20. So I need to be faster about it, right? Granted, when I'm a senior, I'm not going to be writing notes, which is going to make things a bit faster. But so, anyways, that's just kind of my workflow right now, to be thorough, to make sure I look at every single thing. Okay. And that's the morning workflow. The other workflow I want to talk about is the admission workflow. And I got a lot better at admissions, both right now during my nights rotation, and then also during my ICU rotation, because ICU really forces you to look at the way the ICU writes their notes is a system based, neurologic, cardiologic, or respiratory, urogyne, I'm sorry, genitourinary, so on and so forth. It really forces you to make sure you thought about every single system, right? And so that also makes you better on the boards, because it gets you in that habit of thinking about everything. But anyways, I digress. I won't talk too much about the ICU. That's its own thing. A new patient comes, they have a chief complaint. Sometimes it's an easy chief complaint, shortness of breath and fever in an asthmatic patient. Sometimes it's like, what the hell? It's 90-year-old patient is feeling dizzy. 90-year-old patient at assisted living care facility fell. Differentials is wide. The potential problem list is wide. What do you want to do, right? What's kind of the workflow here? And this is something I'm still trying to work on. I still need to get faster at admissions, so I don't think I have a perfect workflow here. But what I've gotten better at doing is this. First things first, I'll very briefly skim the chief complaint. If the ER put a note in, I'll read that ER note. Oftentimes, the ER hasn't put a note in yet, and then I'll put aside the documentation and make sure I look at all the objective stuff. And then so I'll print the patient's sheets again, so I have something to write on. And then again, like I talked about before, look at the vital signs. Is the patient febrile? I mean, or does the patient have low blood pressure? Okay, hashtag hypotension. That's a problem, right? So you got to make sure you want to put that problem in your note. Is the patient tachycardic? Hashtag tachycardia, right? So on and so forth. Look at the vital signs. Look at the labs. Does the patient have an elevated white blood cell count? Hashtag glucocytosis. And of course, when you actually write your note, you might pair these problems with other things once you figure out the reason, right? So instead of just, when I'm writing my note, instead of just having hashtag glucocytosis as the problem, with the list of things, I might have hashtag sepsis, most likely secondary to cellulitis. And then underneath that, I'll put hashtag leukocytosis, because those two problems are connected, right? And then underneath that, I'll write like a couple sentences explaining what I think is going on, and then dash fluids, dash antibiotics, dash, so on and so forth, right? Um, Anyways, look at the vital signs, look at the labs, put all the abnormal stuff down, write that all down, right? Look at the diagnostic results if there's already been some workup in the ED. I mean, I guarantee you, most of the time, not all the time, but most of the time, they've already done an X-ray. So look at that X-ray. Um, if you at least read of the X-ray, right? I'm gonna be honest, I'm not a radiologist, and I don't have the time to actually, even though they tell me to, I don't always have the time to like actually look at the image, right? But look at the read of the X-ray and make sure, or the CT scan or whatever, and make sure you note down every abnormal finding, not just the findings because the radiologist will write this long thing, and then there'll be a thing at the bottom which says like impressions with one or two lines. So obviously those are the very important findings you need to make sure you write down. But make sure you kind of read that whole thing, or at least skim it and note any abnormal findings that the radiologist described. Um, so you look at the diagnostic stuff, um, and then you'll look at the notes. You'll look at the patient's. Hopefully, the patient has been getting healthcare at your hospital. So hopefully, they have a note listing all their past medical history and their medication list, and so you can add all those problems to your notes. So then, already before you've seen the patient, you have a good problem list right now. Now you don't necessarily know, the cause of their presentation still, but you know everything that's going on. And then all of this should take maybe maximum like 10-15 minutes. Okay. Um, and then because that last thing, the notes and stuff, or like the problem list, you'll have that stuff printed on your sheet as well. So you shouldn't be looking too deeply into that. You can look at it more deeply after you talk to the patient. So anyways, you have all that stuff down. Then you go talk to the patient, and having all that context is also going to help you get like a focused, HPI focused history. When you talk to the patient, you want to make sure you get like again, um, in the first and second years of medical school, they teach you how to take an HPI, and then you do like general surgery rotation and OB-GYN rotations or whatever, and then you just like slack off for all of your fourth year, and you kind of forget how to do an HPI. Um, you really need to get back to the fundamentals and make sure you do a good HPI. You know, um, make sure you ask about the main issue, right? Onset, location, duration, characteristic, aggravating factors, relieving factors, treatments, et cetera, et cetera. Um, you know, ask about their past medical history. Ask about oftentimes in internal medicine, the patient's so old that the presentation is one that the family history isn't super important. But if it's important, you want to ask about that. You always want to ask about drugs. Always want to ask about allergies. Always want to, at least in my hospital, you always want to do a med rec, okay? Because um, I don't know. Oftentimes they don't do a very thorough med rec on admission. So if the patient's like, or if the patient's family member, if they're like alert and stuff, you want to do a med rec with them. Are you taking this medication? Do you know why you're taking this medication? So you want to do a thorough history, and then you want to do a thorough physical exam on admission, right? So, you know, on a daily basis on words, maybe you can get away with doing more of late focused, physical exam, right? But on admission, you want to do a better physical exam. General appearance, you want to look at that. You want to listen to the heart, listen to the lungs, palpate the abdomen, listen to the abdomen. If there's any reason for altered mental status, acute metabolic encephalopathy, um, you want to do a neurologic exam. And a neurologic exam to me, it's daunting, because it's like there's like a million things on there. At least how I learned it in medical school, there's a million things on a neurologic exam, but it's actually super easy. You know, you feel my fingers on both sides of your face. Um, can you smile for me? Can you, so that's, you shine a light through the eyes. They follow your eye movements. They do the finger to nose test. Okay. Cranial nerves are intact. They shrug your shoulders, and you feel this on both sides, go down to your legs. Then you do the strength testing. So, as long as you have a method for it, the neurological exam shouldn't be that hard either. Okay. Um, so you do all of that. Um, then, uh, and then one more thing I just remembered, going back to like the vital signs. If a patient's hypoxic, you always want to note that, right? That's just, again, so yeah, if a patient's hypoxic, if a patient's hypoxic, that's a problem, right? acute hypoxic respiratory failure. If a patient is on oxygen and they're not on oxygen at home, that's a problem, right? That's acute hypoxic respiratory failure. You need to have a differential diagnosis for that problem. So then after all of that, you should be able to create a problem list and write your note, even if it's like a weird presentation that you're not super well versed in. Um, so that's just kind of how I run myself through admissions. That's kind of what I do in the mornings. Um, so that's kind of my like workflow right now. I think I still need to get better. You know, I'm still way too slow in the morning. I get there too early, and then I take too long to pre-run and stuff. But you know, it's kind of my workflow right now, and I'm still trying to optimize it. Um, so other learning issues, I'm not going to drown on for too long. I won't make this video too long. Kind of the last thing I want to say is antibiotics, right? You need to get better. It's you need to basically have that antibiotic spectrum in your head, right? And kind of basically off the top of your head, you should know what are the antibiotics which cover anaerobes, and in what situations we want to cover anaerobes, right? Usually in GI infections, you want to cover anaerobes. What antibiotics cover Pseudomonas? What antibiotics cover MRSA? Um, what antibiotics cover staph, just methicillin sensitive staph, right? Um, you want to kind of know all this stuff off the top of your head, right? So for there's a lot of different types of broad spectrum antibiotics, but if a patient has cholecystitis and what do you want to start them on, right? Well, you want to cover anaerobes. Um, and so what kind of antibiotics cover anaerobes? Well, Augmentin does, Zosyn does, piperacillin tazobactam does, carbapenems do, clindamycin and metronidazole do. Well, if you want broad spectrum coverage, if you're worried that there might be other sources of infection besides just the abdomen, or if you don't know if the infection is systemic or not, you'll probably want to do Zosyn, piperacillin tazobactam, because that covers other things too. It covers Pseudomonas too. It has very good gram-negative coverage. It covers all the gram-positives except for vancomycin and enterococcus. So anyways, you just need to know these things, right? For pneumonia, standard treatment is ceftriaxone and azithromycin. Ceftriaxone is covering the gram-negatives, it's covering the gram-positives, except for vancomycin, except for enterococcus, which enterococcus shouldn't be causing pneumonia anyways. Azithromycin is covering the atypicals like mycoplasma and stuff, right? But if you're worried about Pseudomonas, is ceftriaxone covering that? No. So you want to expand coverage. Well, you can do cefepime or you can do Zosyn. Well, Zosyn is going to cover the anaerobes. Normally, we don't need anaerobe coverage with pneumonia. I guess I don't know. I'd have to look it up. Maybe with aspiration pneumonia, you might. I don't know. But normally you don't want. So normally cefepime, which is like basically ceftriaxone except with Pseudomonas coverage. Normally that will suffice. If you want to cover Pseudomonas, and of course you should know like the risk factors for Pseudomonas in pneumonia, which I don't necessarily know all of them off the top of my head, but like recent hospitalization, structural lung disease like bronchiectasis, very frequent COPD or asthma exacerbations. You want to cover Pseudomonas in that case. Do you want to cover vancomycin? Is this like a hospital-acquired pneumonia? Do you want to cover MRSA? Well, then you want to add vancomycin, right? So, anyways, you need to have a good understanding of the antibiotics. The way I've managed to do this is kind of I have an antibiotic spectrum from medical school, and what I did is I made a bunch of Anki cards where I just kind of covered all those antibiotics on that spectrum chart, and then I uncover those right in Anki. So so that's kind of how I got better at my antibiotics. But that's something you need to be more well versed in on words. So yeah, those are kind of my learning issues so far. I'm gonna keep working hard, and yeah. Otherwise, things are looking good. Yeah, as good as I can hope, right? I gotta keep working hard. It's Ramadan. I'm gonna eat my my breakfast before starting my fast soon, and I'm off tomorrow. So I'm gonna study for step 3 tomorrow. I'll make a video about step 3 later, and yeah, So that's how things are going now. So have a good one.